Thank you. Welcome, everyone. I hope that you all were able to join one of the earlier focus area sessions. We apologize for the short break in between, but we are very thrilled that you're here to talk with us and listen to us regarding a very important topic, reunification. Next slide, please. So the Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, HHS, as part of several cooperative agreements. The content presented here is that of the authors and does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. For more information, visit hrsa.gov. Next slide, please. There are no disclosures of any financial relationships or support of any kind related to our speakers. You'll get more information later about how to claim CE. Next slide, please. You know we're all excited that you're here. Please leave your cameras on if you can. As always, the session is being recorded, and we will get the recording and the slides online as soon as we can, and we'll send the follow-up message about a week after the session as well. If you can put your questions in the Q&A box or even in the chat box, and we will do our best to answer those or have others answer them during the session and any discussion times. We already talked a little bit about CE. I will say that the CAPC credit was not approved for this session, but it will be available for the April session. And you probably have heard about the Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals, affectionately known as PDPAC before. It is in the final stages of review. It's a real exciting, lengthy, comprehensive survey of children's hospitals and their preparedness and response efforts. And we hope that everybody that is part of the DRC, as well as any children's hospital external to the DRC, will take the time to complete that survey when it's released. More information will follow. Thank you. Next slide. Okay, 2 seconds here. These are the objectives for today's talk. Thank you, Anna. And I'd like to turn it over to you, Anna Lynn, at your convenience.
I think I'll turn it over to Christy for introductions.
Just wanted to introduce the team that's here. We have several of our members that were missing when we did our initial focus group presentation are able to join us today. And that's Dr. Sarita Chung. Sarita, if you want to say hi, for Boston Children's, and also Brittany Blosser from Children's Mercy in Kansas City. And you'll be hearing more from Brittany in a little bit.
And we also have Michelle Pintea.
Tracy's with us today, and so is Michelle Pintea. So I think we're all here on board today. If you want to come off camera, if you have that capability, Dr. Pintea and Dr. McKellen, that'd be great.
Yes, hi everybody.
Great. So we have an amazing cohort of institutions and healthcare systems that are participating in the DRC reunification. So these will be your partners over the course of the next 18 to 24 months as we progress through the collaborative. As you can see, we have sometimes we have more than one hospital in the state, and I think that's designated by the striped lines, and the solid purple, which is my favorite color, are noting one institution in that state. We'll do kind of a brief Here's the list of all of the hospitals who you will be partnering with over the course of the collaborative. I'm happy to say that we have 23 children's hospital teams total who have signed up for our focus area, and 7 of those 23 chose this as a second project. I can't imagine working on 2, but good job for those of you who are able to. Just as kind of a group activity, for those of you, we'll go through different regions of the country, and then just we'll do kind of a wave. So if you're on the west side, on the west coast and west area, and that includes me, you can go ahead and wave your hand so people know who you all are. And then, oh, that's a good idea, Bree, to actually raise your hand in the in the Zoom. Amazing. I wish I could do that right now. It's going to distract me a little bit too much as I'm running slides. Then how about the Southwest?
Anna, I'm gonna pull an audible on you all. If you want ahead as we do this roll call across the country, if you just want to put your name and your institution in the chat along with waving, that would be fabulous. Thank you.
Great. I didn't see any hand raising, but I can't see everybody right now. And then how about the Midwest? Awesome. The Southeast? Yay. And the Northeast? I love it. I love all of these reactions. I forgot about that function. So great. Moving on, we are going to go to our first poll. And this poll is, why did you choose pediatric patient tracking and reunification as your focus area? This is an open response. It'll be an open text response. And I'm actually going to change it to the response page so that you guys can actually see things coming in real time. And we'll hang on. Real life experience and no patient tracking. Nice. Patient identification. An important piece to many responses. Comprehensive planning. Yeah, I think that is always a challenge. Oh, child life specialists. I love our child life specialists. We work very closely with them. Oh. Not confident patient tracking. I see that concern that the plan might not work. And formalizing a plan, actually, some places don't have plans, updating plans. And you can keep answering. I'm just going to move on in the interest of time, but keep your answers coming. We'll keep the poll open. I'm not sure if it'll stay open once I move off of this slide, but I want it to stay open. So I think it'll stay open until I open the next activity. All right. So if you weren't able to attend our January 7th session, we're going to do this January 7th session in 60 seconds. Okay, but we're not going to go into any depth. So if you're really interested, the recording is actually on the PPN DRC website, and you can actually look for more in-depth information there. So when we talked about reunification in our introductory session, we broke it down into the 4 S's. So some spaces to think about planning for and having available are the pediatric safe area where you can house medically cleared pediatric patients who are in need of reunification, a family reception area or an intake area where you can receive families who are looking and searching for loved ones, a reunification area where the reunification actually takes place, and an area to stage for media present. These areas should be separated, and you may need to consider some controlled ingress and egress with security presence. The second S is the supplies, ensuring that you have age-appropriate nutrition, toiletry, and clothing, including diapers, and distractions such as toys and games, tablets, and crafts. And then there are so many people that are involved in reunification. We can't list them all in a 60-second slide, but including your pediatric clinicians, your child life specialists, your social services folks, facility securities, and so many more departments will need to be involved and engaged. And then from the systems level, really understanding your leadership and organization for when these activations when these activations happen. Processes, including patient tracking, which I think was a big theme, family intake, and then information sharing, as well as legal considerations, not only with information sharing, but with respect to actual reunification. I think here are a couple of the polls that we put, well, 3 polls. We had a pre-poll and a post-poll, and what we really saw was we went from a pre-existing phase of not having a plan, not having thought about a plan. So nobody actually did that in the retake. And then there was an interesting shift where people thought, oh, we're kind of in this adolescent phase where we have a really good plan. We've tried it, but maybe it could use some improvements. There was a shift from that adolescent phase into this school age phase, because we're all pediatricians, well, a lot of us are working with pediatric patients, but the school age is where we have a plan, but we've actually never exercised it. So there was that interesting shift of, oh, we thought we had a pretty good plan, but now maybe we need to figure this out a little bit better. The biggest concern by far was staffing in the setting of reunification. And the second was systems-based issues. When we went into facilitated group discussions, some of the themes that we had broken out by those 4 S's were really having and identifying secure areas to establish those areas we had talked about, traffic, privacy, and not having enough space within the hospital footprint or the medical center footprint, supplies, including forms and tools for tracking, and then all aspects of staffing for the entire process, having appropriately trained staff and how to manage staff turnover and training, and then staff to continue normal operations and reunification at the same time. So it's hard when you're calling on the same person to fulfill 2 roles, their normal daily operating job and then another role with respect to reunification. Systems-based issues and themes that were identified include communication with not only the media, but interfacility communications and also external agency communications, identification of unaccompanied minors, tracking and consent, education and training on the plan, and HICS activation. A couple of resources that you should have received in the pre-session email include the toolkit for healthcare facilities for family reunification following disasters. This was co-sponsored by the American Academy of Pediatrics, and a lot of the leaders on this call were involved in that, as well as the Massachusetts General Hospital Center for Disaster Medicine. And then everything that we're basing our work on is on the EMSC for the entire DRC is the EMSC checklist for pediatric considerations for disaster policies. And specifically, we're really interested in domain 6, which is on page 14 to 16 of the disaster checklist. And so I can't see chat, but hopefully somebody is adding these links into the chat at this point, in case you don't have them already. We will be having trying to house all of these resources that we present on the PPN DRC website. And Regina, I see your hand is raised. Maybe you can put something in the chat, or maybe that's a leftover from before.
People be able to unmute to ask questions, or do they need to put them in the chat?
I think let's have them put them in the chat for now.
I think the chat is disabled, so they'll probably need to put them in the Q&A right now, and so we can try to answer questions. We apologize for that. We'll try to figure that out during the session.
Sarita, I can change it if you like.
Yeah, let's let everybody be in the chat and also be able to unmute. That would be great.
Sure, will do.
So without further ado, I'm going to turn this over to Christy to actually introduce our next amazing speaker.
Just having trouble unmuting. Sorry about that. Brittany, I'm not going to read the whole bio we have on you because I'm going to let you talk a little bit more about yourself and your experiences and your background. But Brittany's in the emergency preparedness business continuity at Mercy Children's in Kansas City. Sorry, Children's Mercy in Kansas City. She's been doing this work for quite a while. She's led several exercises, not just at her hospital, but for their healthcare coalition. And if you were recently joined the DRC fireside chat, she led the fireside chat on the toolkit that they developed at Mercy Children's on drills and exercises. Brittany, go. It's all yours.
Good afternoon, everyone. Thank you, Christy. Yeah, so I work at Children's Mercy Kansas City. I am part of the emergency management and business continuity team. So we do a lot of exercises, but one of the things that I've been working on the last 3 years is actually reunification internally, as well as working with community partners on kind of establishing a more comprehensive plan within our community. So before we jump into our main discussion, I want to start with an interactive exercise. If we can go to the next slide, please. So think about an effective team that you've been a part of, whether it was at work, in the community, or even a personal project. Think about the characteristics that made that team truly successful. In the word cloud or the poll everywhere, enter the words or phrases that come to mind when you think about characteristics that made your team effective. Open communication. Give everyone a minute to put some stuff in. Teamwork, mutual work. Is it moving a lot for you, Anna? Okay.
I was going to say, I haven't seen anybody put in, oh, I saw it. Trust was the word I was looking for.
Clear
It's like it's slowing
expectation.
down now.
Respect. I know, as I was trying to read it, I was like, whew, it's going a little fast. No, it's amazing to see all of your thoughts and responses coming together. So as we can see, communication is definitely a big one. Chrissy's point, trust, leadership, engagement.
Do I see listening on there? Good listener? Falls in with communication probably.
Respect is a big one. So yeah, as we can see, these are all some top characteristics that make a team effective. These qualities are fundamental to not only everyday teamwork, but especially when we face complex challenges like emergencies. Next slide, please. So now that we've explored some characteristics that make an effective team, let's dive into how to build a strong planning team for reunification. A successful plan starts with an effective, well-rounded planning team. Representation from multiple hospital departments is essential to ensure that your plan covers all aspects of hospital operations, patient care, and family support. It's easy to see why your emergency department and security should be involved for reunification, but some of the other roles may not seem as obvious at first. So I'll walk through a few of these, though this list is by no means exhaustive. Let's see, reunification doesn't always have the outcome that we hope for. So we have to also consider those difficult cases. Spiritual services can provide emotional and religious support, while the hospital's pathology team or coroner may coordinate with the community ME when needed. There's also legal considerations, particularly around patient health information and the specific legal complexities of children in disaster situations that we also have to address. Language and accessibility services can ensure that critical forms and instructions are available in multiple languages, and also that interpreters are present during reunification efforts to support non-English speaking families. Another key stakeholder is going to be your telecommunications team. So during an emergency, we know that call volumes are going to spike. Phone systems can become overwhelmed. So this team can ensure internal, external, and hotline communication functions are function properly to prevent breakdowns. We experienced this firsthand at Children's Mercy during the Chiefs Super Bowl parade incident last year. It wasn't just family members calling, but as you can imagine, news outlets were trying to get a hold of anybody and everyone that they could. Calls were coming into random departments, and our operators didn't really know where to direct them. So while we didn't have many family members arriving in person, since most children were already with their guardians, we did activate our reunification plan primarily to establish a dedicated call line. From that experience, we've since worked with our telecoms team to develop a call flow to include pre-scripted messaging. Another team is going to be your patient access or registration teams. They play a crucial role in capturing unique identifiers and ensuring children can be accurately tracked in the system upon arrival. Instead of creating a new process from scratch, we actually adapted our existing mass casualty incident disaster form to include key reunification data. So in many cases, like hospitals already have processes in place that, while not formally designated for reunification, they can be refined and integrated into the plan. With the right people at the table, you can then streamline these efforts, avoiding the need to reinvent the wheel. Beyond simply just creating a plan, this planning team really becomes your hospital's reunification champions. They've invested because they're invested because they've helped develop the process, and following an activation, they're most likely going to be the ones identifying needed improvements. Our organization is currently transitioning to Epic, and during our development meetings, others, not just our EM team, have brought up the need to integrate patient tracking and reunification into the new system. So once you build a strong planning team, it's no longer just you advocating for these initiatives. There's shared ownership, which really applies to any emergency plan. But if you develop it in a silo, it's just not going to work. This brings us to leadership and oversight. Your team should consist of individuals with authority to make decisions. For our team, we started with directors and senior directors who then pulled in key managers. For instance, our Director of Care Management and Patient and Family Services, or CMPFS, identified leaders for spiritual services, language and accessibility, guest services, child life, and social work, all of which fall under our CMPFS umbrella. This approach ensured we had the right level of leadership to drive the plan forward, while also engaging those directly involved in reunification efforts. I'd also recommend securing an executive sponsor to further strengthen organizational buy-in, and it provides the high-level support needed to keep the work moving forward. Finally, set a consistent meeting cadence from the start to keep things on track. Our planning team met monthly, and as we identified gaps, we would assign plan components to specific individuals. Many of them would then hold smaller working meetings with their teams before bringing updates back to the larger group. Your team should determine what works best within your organization, but the key is really maintaining momentum. With the right people at the table, reunification planning becomes more than just a document. It becomes an operationalized, sustainable process that strengthens your hospital's ability to respond effectively, especially when families need it most. Next slide, please. Just as an effective hospital reunification plan requires a strong internal planning team, it also depends on coordination with key community partners and external agencies. Hospitals don't operate in isolation during a large emergency, so our efforts really do need to align with broader community reunification strategies to ensure a seamless response. Public safety agencies such as law enforcement, emergency management, and EMS are going to be essential partners in maintaining security, controlling access, and facilitating the safe reunification of children with their families. They're also going to provide critical situational awareness and logistical support during large-scale incidents. As mentioned earlier, reunification doesn't always have the outcome we hope for, and in those cases, coordination with the coroner or ME is necessary. Community reunification agencies like the Red Cross or another designated reunification partner, they can bring expertise in family assistance and large-scale reunification operations. Their role really ensures a coordinated approach across different response agencies. A big one is school districts. We participated in a school reunification functional exercise and quickly realized that without formal agreements in place, information sharing restrictions would actually prevent schools from assisting us in identifying children and their guardians. Knowing that schools often have the most up-to-date emergency contact information and could play a key role in verifying identities during reunification efforts, really by establishing agreements ahead of time, we can ensure that schools are able to support our efforts. Another big one is healthcare coalitions. We actively participate in our coalition's reunification meetings to help develop community-wide processes. But being plugged into your healthcare coalition ensures that efforts are coordinated and streamlined across multiple hospitals and agencies. If a parent arrives at another hospital needing medical care and their child ends up at yours, the coalition can help coordinate with other hospitals in the network to share critical information. So having established protocols through the coalition helps ensure that efforts across multiple locations are aligned. So by engaging these external partners early in the planning process, we can align our hospital's reunification plan with broader community efforts, reducing confusion during an actual event and ultimately reuniting families. Next slide, please. So next we're going to break out into smaller groups for facilitated discussions on strengths of your reunification plans and opportunities for improvement. If there's time, your group may want to also discuss barriers or challenges to planning and any potential solutions to them. You'll have 15 minutes in your group, and then we will reconvene to share out key points.
Laura, before you send everybody off, if you don't know how to look at your strengths and weaknesses and opportunities and everything, I suggest you click on your ED disaster checklist PDF that's in the chat. That's the EIIC checklist that you can quickly, easily look at to see how you can kind of measure, see where you're at, and identify maybe your strengths and opportunities. That might be a tool to help you work through. So I was in group 3. Everyone was great at sharing. I think everybody had a chance to speak. A lot of barriers, challenges and stuff, obviously related to people, but also lots of people are concerned about their space. Having enough space, big enough space, the flow between spaces, and the communication between spaces. So kind of coming back to that common theme. Several of the groups were already starting to look at their plans. And also several of the teams are looking at moving into different facilities or to facilities expanding and the impact of that on their plans. So that was the main discussion that occurred in ours of more gaps and challenges as regards to space from group 3. Sarita, what did your group have to talk about?
Yeah, we had a really robust discussion. I think some of the strengths people had worked out through their plans include identifying like what is HIPAA and what is not HIPAA to make sure we facilitate reunification, and also talking about technology to track patients. There also was a hospital that needed evacuation, and they were able to track their patients to be evacuated, but then when the patients came back to be reunited with their families. And so working through that, we also have participants who hospitals may have they're very in the beginning process of creating plans. So really wanting to hear what other barriers are for other people and how they came around it. I think one barrier I noted was like really also working with outside agencies and recognizing that hospitals will be people's go-to when trying to find people, even if your child or your family member is not hurt. So I'll turn it over to Brittany.
Hey, yeah, so our group had a lot of the same things. One of the other things that they did identify as a strength, though, is those relationships with their healthcare coalition, which I thought was great. And then one of the opportunities for improvement was kind of establishing those MOUs to make sure that, you know, the first time you're requesting resources or needing to get in contact with somebody, it's not during the incident. And then another really big one was it may look great on paper, but has it actually been exercised? As well as ongoing training and education around those processes. And I'm not sure if there's I'm not sure how many groups we had, but I will hand it off to someone else.
Michelle, what
Okay.
did your group have to say?
I think we had a lot of similar themes. I think some of the strengths that were mentioned was that there's a great framework for the plan and all stakeholders and some space has been identified. And it was also really great to hear that some of the groups had strong healthcare coalition contacts as well that helped them. Some of the gaps I think have already been mentioned by some of the other groups is that while it might look good on paper, no one's actually drilled it yet, so that might change as the drills happen. Also coming up with a good system for matching the parents and the children was a gap. Patient tracking, legal aspects came up as well. I think those were the big ones.
Few things we talked about in our group. So as people mentioned, being part of a bigger hospital system sometimes can be a gap or a challenge, having reunification plans that are targeted more towards adults and don't account for pediatrics. But on the flip side, sometimes that can help you to identify some things that might work well if there's a well-structured adult plan, where some of those core concepts could be the building blocks for a pediatric plan, like maybe how to activate incident command or trying to streamline the process. We also talked about the importance of doing drills, accounting for different times of day. So your staffing is going to look very different at night compared to during the day. And so considering resources and trying to build that into the plan as well would be important. And just a suggested resource that Mass General a good plan that looks at different developmental ages or stages regarding communication and some factors to consider there. So that was something we talked about too, in trying to really tailor our plans for pediatrics.
I think that was
I
all of the
don't
groups.
remember. Well, I had a group too, so
Sorry,
I think it was we had a lot of people who are working on reunification plans that don't have established plans, which I thought was really rich, or at different stages. And so I think if you're an institution that's just really starting out, maybe starting with a smaller bit, and then also talking through, I think one of the things that we talked a lot about is in terms of the spaces, really walking through the spaces and making sure that you're able to control ingress and egress into those areas. Just finding small things to start with, because planning can be overwhelming, and then to borrow and steal without shame. So I know that the Texas Children's Plan is up for everybody to see, and there may be other example plans that we can also share. So you know, maybe taking a look at some of these more well-established plans or sharing plans between groups is a potential solution if you're stuck with starting out. And I open it up to the rest of the group. If I missed any themes, I probably did. Oh, staffing was another thing that we talked about in terms of like having multiple roles for an already resource stretched like social services or child life services as well. I think we really want to optimize these reunification sessions for you. We actually will be giving or sending out pre-session materials. They may come as a link to something or through in your emails that may either have collated pre-session materials or materials that you can just review prior to the session. These sessions are as good as you all as participants will make it. And we hope that you'll actively participate and share your experiences so that we can all learn from each other, and definitely spread the wealth in terms of planning. If you're the team lead, meet with your teams in between sessions to share ideas and design improvement projects or start the planning work, and discuss the progress of the work that's ongoing, and then share and use the DRC resources that we have developed to implement improvement objectives or projects. We would love to learn from all of you, and so reporting your best practices and any lessons learned. Some of you may be starting with a virtual tabletop exercise in the coming weeks. And so we will call on folks to maybe share something that they get out of the tabletop, either a strength or a gap or something that they've learned, and then offer feedback and encouragement, collaborate, share your ideas and all the resources. We did not highlight a resource I did want to talk about, and we'll send in in an email and place on our PPN website, DRC website, and that is the Region 5 for Kids has run a series of modules that are available online. And so we want to send a nod to our Region 5 for Kids colleagues who all participated and created those learning modules and have additional information on reunification planning. And then I think, so our next session is on April Fool's Day. So April 1st, we will be sending out a needs assessment survey so that that is based on the EIIC disaster checklist, so that you can actually quickly assess where your planning is at. And then a reunification planning team worksheet that identifies potential stakeholders and partners that you might want to engage as you begin the planning process. And then just really, I think reunification is a very big topic. And so as we had talked about earlier, just starting small. So maybe identifying one aspect of reunification that is achievable to actually work on with your stakeholders will be helpful to start moving that needle towards better preparedness. So we will send out some worksheets on setting a SMART aim and goal. And we will have some examples of that at our next session that are specific to reunification. I'm going to turn this over to Laura.
I was going to ask if you wanted me to handle this one. So we haven't talked about the virtual tabletop exercises or the option to do your own facility tabletop exercise, or the option to opt out because you've already had planning recently or you have another reason. But those of you who are here are likely on teams that identified focus areas and whether or not you wanted to participate in a virtual tabletop exercise that's hosted or a tabletop exercise. So if you haven't yet had a team that did that and you just came here because you were interested in the topic, please email. Or if you have any questions, please email. We just got approval for all of the BTTX materials to be ready because some of the exercises start as soon as next week. But if you have questions, reach out. If you need help with something, reach out. You can see the cadence of the collaborative sessions. Now we'll be doing 2 focus area sessions for 2 months, and then we'll all come back together for the 3rd month as a collaborative. And then you can see later on, we'll be talking about drills, a pre and a post drill with a measure where you might want to identify something specific that you want to improve. I think that's all I'm going to say about the drills, but if you have questions, please let me know. Next slide, please. We have a lot of resources and we are here to help you. I wanted to do a big shout out to the co-facilitators who have worked tirelessly for more than a year to get ready to bring you this collaborative. And soon we will have focus area web pages posted, hopefully before the April 1st session. And then you can see the other benefits of being part of the DRC. If you didn't attend all of the sessions earlier on, you might want to take a look. They're all online, and especially the last 4 where we focused on those focus areas, you might want to listen to 1 or 2 of those again. Next slide. Anna's pretty much already covered this. Anna or Sarita or Christy, did you want to talk about the bullet points in regards to what's going to come up next session?
I think the next session, we're really going to focus on the first 60 minutes of activation. And in addition, we wanted also a focus on communication, because I think communication in any type of disaster response, there's always a lesson learned from communications. And so definitely we wanted to include that kind of upfront and early. And again, we talked about some of the resources that we'll have available for you as you guys embark on your planning or improving your plan. And then hopefully we would love to hear from anyone who has participated in a virtual tabletop, which I think the first one will be in March, I think March 18th. And we'll have another facilitated small group hospital disaster plan review. But again, more to come, and we're so excited.
I'll add to that too. If I might have already said this, so my apologies. It's been a long day. If you signed up and registered for this session, you'll also be registered for the April session. But if you want to, you can re-register as many times as you want. It's easiest to register and pop right on in at the time of the session, but that's my preference. Next slide. Ready Prep Go is awesome. It's a podcast series, and I can see some people who have already talked on a podcast series. And if you're running or walking your dog or just want to listen and be inspired or amazed by what people have gone through, this one just came out recently, so we always like to promote it. You can find Ready Prep Go on the homepage of the PPN website. Next slide. This is to remind you of how you get your credit. Let me see if I can put that link in the chat while I'm talking. If you need help with acquiring credit that you need, please reach out, because we have a really awesome helper person who, if you get stuck in a corner somewhere and don't get what you're supposed to get, she can get you out of it and give you the credit that you need. And then I think the next slide brings up the thank you and the session evaluation poll, which is just 8 questions. So please do your best and answer. And then once you're finished, if you're not a facilitator, please exit. And thank you so much for coming. Thank you to all the facilitators and the leaders of this group. It is amazing what everybody does to help kids and help their colleagues every day.
As you're finishing the poll, if there's something very specific that you want to make sure we talk about in a future session, throw that in the chat. We'll talk a little bit more about that next week or next month, after you've got a chance to go through your assessment. But as we're building these sessions for the next year or so, if there's something you want to make sure we talk about and cover and have an expert on it, or someone who's experienced that particular topic, please throw it in the chat so we can start planning for those future sessions. Thanks.
And we're all here for you all. And so really, we look very carefully at the session evaluations to make sure that they're still relevant to folks, and that we're actually addressing the needs of the participants in the collaborative. So it's so important to us. So we really appreciate the time that you're taking to complete these evaluations, and we're always open to additional feedback. We have I think Laura put her email address in the chat, and so anything that you specifically would like to hear about or want us to do better, to change, we're always open to all of that feedback.